Okay, so good morning to Nigeria, to America. Good evening to India and good afternoon to Nigeria and Europe. नमस्कार. सबसे पहले मैं अपने आदरणीय संतोष जी को नमस्ते करता हूँ. I'm very happy that we are able to have him despite his very busy schedule. Jack, let me and further I introduce. First, I keep on introducing everybody. Jack, and you keep listening. Then I'll introduce you later. So, Honorable Santhosh ji is a General Secretary National of Bharatiya Janata Party, which is the largest party of the world. And he is also General Secretary organization, and he basically belonged to south of India. And let me read out his credentials before I go to other places, because. Or I will do that a little later when he will start talking. So let me start the panel first. So I am Dr. PK Gupta here. Then we have Honorable BL Santhosh ji. Then we have Dr. Jack Lewin from USA. Dr. MK Das, who is the present Cardiological Society of India President. Then we have our Mr. Atul Garg, who is the State Health Minister, Government of Uttar Pradesh. We are still waiting for Mr. Adesh Gupta ji. I think he will join soon. And then we have other panelists who will be there along with that, Dr. ML Gupta, who is Assistant Director, former Assistant Director ICMR. Then we have Dr. Yashpaul Sharma from PGI Chandigarh, Dr. PK Asokan from Kerala. He's a very senior interventional cardiologist. Dr. Hakim, from our friend from Nigeria. Dr. Hakim, may I just request you to increase your light on your face, so because you're looking dark. So you can increase the light, okay. Then Dr. Jack Lewin, who is our friend, and let me introduce him because I know him personally for last 15 years. He came to our conference in Amsterdam. We used to do Indo-European course on revascularization. He's a past president of American College of Cardiology. He's a past president of and CEO of Cardiovascular Research Foundation. He is presently doing a consultant and also possibly future WHO Director General. I just okay. So सबको नमन करके मैं अनम्यूट कर देता हूं थोड़ी देर के लिए सबको. Then I will request Anshu Anand. She is our person who will be doing. She's actually business health advisor. And then we have Charvi Jain, and then we have Dr. Gopal, and then other people are also already there. So let me start my deliberation. Before that, I will request Anshu to give a small introduction to the meeting. This is the 12th webinar in the series which we have been doing, and along with that we have done four more webinars. COVID-19 is an important topic these days, and it is actually a pandemic, and we all know that this is a problem, and we still do not have any Ramban dawa, and vaccine is far away. So I'm trying to unmute others, but Anshu, you are unmuted. You can start a small 2 minutes introduction, and then I will start my deliberation. The planning will be that first of all I will speak, and then I will request Jack Lewin to give a small talk. Honorable BL Santhosh ji, Dr. ML Gupta, I have the list. I will do that, and then it was timely. We want to finish by 8:30. Anshu, please go ahead.
Sure. Good evening, everyone. I would like to take the opportunity to introduce Vivek Gupta. He, as we all know him, he has been a senior interventional cardiologist with Apollo Hospitals since 1998. And a lot of his background has been around researching and innovation that is around angiographies. We may be pleasantly surprised to know that during his career he has done over 10,000 coronary angiographies and more than 5,000 coronary angioplasties and stent implantation in India and all over the world.
Yeah.
He has been instrumental in starting primary angioplasty, which is doing angioplasty during heart attack and multi-vessel angioplasty and stent implantation. He has worked all over the world. His his major work was in a very large hospital of France called the Hospital Charles Nicole Ronde during 1996 to 1998 with a very renowned professor who is also the innovator of TAVI, which is transcatheter aortic valve implantation, and world authority in the field of angioplasty and valvoplasty. And now we have, after his great career all over the world, we have had the privilege to have him in India, serving people here. So
okay. So I think we start my presentation. So we're getting late, and we have to invite other people as well. So if everybody permits me, especially Honorable Santhosh, I will start a little brief introduction of the COVID-19, and I will start sharing the slides. So this was actually the flyer which you can see, which we had all the people here, and I've already introduced Jack Lewin, Dr. Kim, Dr. M.K. Das, Dr. Girish Tyagi is join soon. I have to actually unmute everybody, so I am short of staff. So somebody has to mute. Okay. So this is a talk, and then I will show.
Rajkumar, इधर दे दो.
ये पता
नहीं क्या टमाटर है छोटे.
I have to unmute somebody. Somebody has to unmute.
धो के रखना, देखो खाने में ऐसे ही खाने के साथ.
Let me unmute everybody.
नहीं, ये टमाटर है कि पता नहीं क्या देखा.
बोल रहा हूँ सब्जी की वाला टमाटर चाहिए थी.
नहीं ये अलग है, ये वैसे
टमाटर करके लगे बता रहा हूँ.
हाँ ठीक है. अच्छा ठीक है.
धो के रखो इसको या
हाँ धो के रखो इसको.
Okay, I think I have to overrule that because I'm not able to unmute the person who's speaking about tomato. So let us come back to Zoom, and the new share is this is my topic. Sorry, I have to share my slides.
हाँ जी. धो के रखो, देखूंगी कोई सैलेड के साथ. इसको बड़ा कर.
Sorry for the little time because I have to share my slides. And I'm a little short of my staff today because it's okay. 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 So can you see the screen? Ashokan, can you see the screen now with the?
Yes, we can see it.
Okay. So this is the topic which I have to present, and this is now like this. So COVID, I start and finish in 10 minutes exactly. And COVID-19, SARS-CoV-2 is a big mess now with a total global perspective today is 9.95 lakhs people affected, close to almost 9.5 million, with about 48 lakhs deaths. A global perspective, you see the first million came in April 2 and 25 June is 9.5 million. So this is increasing steadily, and especially in India. And doubling time, India is 14 days and Turkey 37 days. I would like to show you the slides, Indian perspective. On 5th June, it was 2 lakhs, and today on 25th June is 4,74,000. About touching 14,000 deaths. US perspective is the worst affected country with 24 lakhs people infected and about 1,24,000 deaths. So coming on to the highlights of June, the daily coronavirus death in Italy has been going down. If you see till 31st May, the graph has gone down. Brazil is growing up, Russia is growing up, Spain is going down, but as such, Delhi is peaking. Whether it is because of increased number of testing or the number of cases, and because we have started a lockdown, so we are a little worried. Economy was very important. That's why it was a lockdown was done. So the contact tracing, I will not talk about here. Lockdown may still be necessary, but we are discussing with the ministry and other people. Lockdown is still not possible, and the graph is growing up, as you can see here. they started their lockdown because they wanted her. I think I have to unmute. I have to find somebody to help me out. Class is causing too much of noise. I have to try to unmute everybody. There is a small thing which is to unmute all. It's not getting here. I think that's gone. So the vaccine is possibly 1 year away. This is important. May 28, have you seen India was number 10, and June 25, India has gone to number 5. Sorry, number 4. So now only Brazil and Russia and US are ahead of us, and Italy, they have started containing the thing, and you can see that Italy, the number of cases are still only 238,000 despite the best of testing. They are testing about 60,000 per million. We are not testing more than 10,000 per million as of the today figure. I may be a little down and up. So that means that India is, we are still concerned about the number of cases rising. I will like to share this important slide for everybody to see. When nation is locked down, Peru, Mexico, Chile, Brazil, sorry, not Brazil, USA, United Kingdom, Spain, they started lockdown, unlocking.
You are not audible, Dr. Vivek. You are not audible.
Not sleeping, but article Parliament very
दोबारा कर देंगे तब जल्दी बंद हो जाएगी. अगर अनम्यूट कर रहे हैं तो वो नहीं रही, चक्कर क्या है? मुझे नहीं बताओ.
सही है. ओके, अभी अनम्यूट है.
ये म्यूट है ना ये तो.
जब इस पे क्रॉस लाइन बन जाती है तब अनम्यूट.
हाँ तो ये अनम्यूट करना है मुझे.
सी साइड पर.
अच्छा ये जो अभी जाओ.
Can you hear me now?
Yes.
Is it okay?
Yes. Yes.
Okay. Sorry for the delay. I'm again sorry for the system, and late evening Apollo is not working as of now, and we don't have staff. Okay, so I go back to my slides. I will try to finish in 5 minutes. So we are little concerned because all the countries stopped the lockdown, but they did unlock down when it was okay. But our graph is going up. This is how we are working these days with the public. This is the angiography lab. You can see in Apollo Hospital with personal protection kit. I tell you, everybody, that we were even not wearing the mask and face cap. But now we have to protect it. Healthcare workers are the worst affected. This is how Apollo started with the numbers of initial hospitals were Max and Apollo in the private setup. And this was a video made by the R Bharat where we were talking about how Apollo is prepared. As of now, we have 300 beds in Apollo Hospital, which is serving. I have already more than 25 patients admitted under my care, which are known to me, and they have cardiac patients. So we are fully prepared, but still the beds problem is overwhelming in Delhi. We do angioplasty like this, and you can see the other people are watching. Let me tell you, this is Facebook Live at various places, including India and Paris, which have more than 25,000 people. So economy-wise, word is affected. This was Angela Guerrero speaking to France 24 about 3 weeks back, and they said this is the worst year. Coming back to the disease, it's a virus disease which affects the lung and the heart equally. And this is the coronavirus replication, and this is corona S protein has been reported as significant determinant of virus entering the host cells. The most important part is the antibody formation, which is IgM and IgG antibody. This is for medical people to know. And because of this, we are able to do plasma therapy, because plasma therapy is dependent upon IgG and IgM antibodies. IgM antibodies, they finish at 12 weeks, while the other people, they start coming. Cytokine time is the worst thing to happen, and that is why interleukin inhibitors are effective. Diagnosis basically made by the clinical symptoms and also RT-PCR testing. But the RT-PCR test take about 24 hours to come, which is from the respiratory secretion. But the new antibody test, antigen test has been now recently introduced, and which is, let me tell you the difference between the two tests. RT-PCR test, which is taken from the throat infection, has a high sensitivity but a low specificity. Means if you are positive, you are 100% sure you have coronavirus disease, but if you're negative, you can again become positive later on. This is the difference between the other test, which is rapid test, rapid antigen testing, South Korean kit, results available in 30 minutes. This is also being done by the government now. Government is using this kit now. This is also a nasal secretion, which is high specificity but low sensitivity. That means if you are negative, even if you are negative, you have to confirm by PCR test. This is the difference between the specificity and sensitivity. Radiological diagnosis is done by the CT scan. Sometimes the tests are negative and you still have a lot of symptoms. I give you one example where there was a patient who was tested negative only 3 days back in Apollo, and he had symptoms which had like pneumonia. Our hospital said to repeat the test and do the CT scan, and we did not have ICU at that time. So finally we had to repeat the test, and we found that it was actually positive. What I will tell you, everybody, PCR test, if it is positive, is always positive. That means you are 100% sure you are suffering. But if it is negative with the classical symptoms of pneumonia, of fever, you are not too sure because it has a low specificity. Then, of course, you have to take care of CT scan and other things. So I told you antibody test is a test which is now not being used much. This is basically to find out whether the patient has been exposed or not, which is NIV Pune is doing. So I'm just giving a few examples. India is testing about 9,000 to 12,000 per million. China, it was found to be faulty. It was returned back. That was a few days back. We have to test the viral load, which we are still not doing, to know whether the patient is infectious or not. Medicines work at various levels. Hydroxychloroquine work here. Remdesivir and favipiravir works at the level of mRNA. What are the medicines available? We have 5 groups of medicines available for the patient treatment, which is hydroxychloroquine, ivermectin, antiviral remdesivir, favipiravir, which has been recently FDA approved and also approved by the Indian Drug Controller Government of India, IL-6 inhibitor tocilizumab, and inhaled nitroxoxide. But despite the best of medicines, the mortality in Delhi per se is about 5%. Overall, India mortality is about 3%. I'm not going to details about hydroxychloroquine. I think I've taken already more than 10-15 minutes. Hydroxychloroquine is very good for the prevention, for the healthcare prophylaxis. I still say it's ICMR clearly said for healthcare workers and people in the field who are meeting. Now there is an unlockdown. I would say that everybody with ECG, once do the ECG, ECG is normal, QTC interval is normal, take this dose, hydroxychloroquine 400 mg twice a day for 1 day and 400 mg once a week for 7 weeks. I advocate this medicine. It's a simple medicine, does not have major side effects. It has only side effects when the patient is suffering from heart disease and when the patient is having cardiomyopathy, QTC interval is increased, not for general population. So US hospital said it may use SQ as a pose risk. So this lot of controversy, I'm not going to details. Repurposed medicines, lot of new medicines have been proposed. Dr. ML Gupta, who is ex-director ICMR, will be speaking about this thing, about repurposed medicines. Ivermectin is an anti-protozoal medicine, which is antiviral to the 5,000 times effect. It is being used in Apollo Hospital, although there's no clear-cut human trials. but in patients we start doing this thing. Drug remdesivir is an antiviral intravenous medicine. It is highly important. Yesterday, I tell you, on 30th April, we spoke about remdesivir, but in India, the availability is only recently. Jack, now we have this medicine available. Yesterday, the patient deteriorated. One of my patients who was otherwise involved, we shifted to CCU, ICU, and we have given remdesivir. The cost is about 20 to 20,000 per patient. It is 400 milligram and then 200 milligram intravenous for 5 days. Among another important medicine, which is talk of the WhatsApp, which is favipiravir, is also antiviral medicine. You must have seen a lot of people talking, new medicine come, new medicine came, how efficacious is it a रामबाण or not? जो मेरी मेडिकल राय है, ये ओरल एंटीवायरल मेडिसिन है. इट इज वन ऑफ द इंपॉर्टेंट थिंग. फेज 3 ट्रायल में पहुंच चुकी है. इट इज यूजफुल इन माइल्ड टू मॉडरेट सिम्टम्स. व्हेन यू हैव माइल्ड टू मॉडरेट, आई थिंक इट्स अ वेरी इंपॉर्टेंट फाइंड. It will be maybe useful. Tocilizumab is a very important medicine, very expensive interleukin inhibitor. जो पेशेंट वेंटिलेटर पर चले जाते हैं उनको ये दवा देने की जरूरत पड़ती है. हम लोग भी देते हैं. It's quite expensive, but it is again not a रामबाण. Inhaled nitric oxide. So I'm telling you that lot of patients still they don't survive. That is why we fear. So overall treatment planning is vitamin C, zinc, hydroxychloroquine. Saturation drop hota hai, then we have to give oxygen, and we only admit the patients who have low saturation levels. Otherwise, we don't try to admit. Everybody can be treated at home quarantine, and this is what because unnecessary treatment increases the bed capacity and the load, and the patient actually requiring treatment may not get it. Vitamin D is useful. Yoga, pranayam, exercise, and I will not like somebody else to speak. Use of mask is very important. This is the only way we can prevent. I again tell you that patients or healthcare workers or anybody on the road has to be. I was talking to Dubai people. They said they had done lockdown and the masking to that extent that it was chargeable. Challan. So we have to do that. I spoke on March 29 on Rasheed TV and also on TV9 Bharatvarsh that everybody should wear the mask. At that time, I was laughed away. People ने हंसा कि आपकी जरूरत नहीं है. अप्रैल में अपने प्रधानमंत्री जी ने खुद गमछा पहना. मैंने अंगोछा की बात की थी March 29 को. तो लोगों ने कहा वैक्सीन is still difficult to come. Oxford trial, Italy trial, monoclonal antibodies, Israel, all these things it will take 1 year. Contact tracing, Aarogya Setu map, everybody should have it. I hope everybody knows how it works. Anybody who tests positive, उसका वो गवर्नमेंट के हिसाब से चला जाता है कि उसके मोबाइल पे कि ना हो. 3 हफ्ते तक जो भी कॉन्टैक्ट में उसका आया है उसका टेस्ट पॉजिटिव हो जाएगा एंड पीपल विल बी. यूरोपियन स्टडीज फेविपिराविर ने ये रिकवरी ट्रायल में कंफर्म किया है. फेज 2 ट्रायल, दिस इज इफेक्टिव मेडिसिन. प्लाज्मा थेरेपी इज बेसिकली डिपेंडेंट अपॉन ब्लड ट्रांसफ्यूजन, टेकिंग आउट plasma from the patient who has recovered from COVID. It is useful in few percentage cases. It is still investigational. Herd immunity is still available. Not herd immunity का मतलब क्या होता है? Herd immunity means सब कुछ expose कर दो, lockdown कर दो. कुछ लोग को immunity आएगी, कुछ लोग बीमार हो जाएंगे. But unfortunately, in COVID-19, antibodies take long time. This is how the herd immunity works. Sweden ने herd immunity की कोशिश किया, but they had to really face problem. The death rate, daily confirmed death rate, that is spirally high. So herd immunity is not a choice for COVID-19. It is good for other patients. And coming on to the last part of my slide, how India is preparing, I think that other people will tell. Ventilators should be avoided, as Jack was saying to the last step. Ventilators should be avoided. जो ventilator में चला जाता है उसकी risk life की और बढ़ती है, but somehow we have to take it. Healthcare workers are the worst affected. Many doctors, nurses have died all over India and all over world. Plasma treatment, as I told you just now, China, whether China से उगा है या human चाहे, is a debate going on. One of the Nobel Prize winner said that it is possibly a human-made virus. Heart के patients में mortality ज़्यादा है. जिसको heart patient है उसको 10% patient will die. जो patient 80 से ऊपर है उनके 15% mortality है. और overall mortality इसमें 2.3% है. But in India it is 3.3% और बाकी लोगों में ज़्यादा है. So I finish my talk here and I will stop sharing the slide. Stop sharing the slide and come back to this. And as per the protocol, I think I will give request Jack Lewin to come in, tell about America a few minutes, and then Honorable Santhosh ji will speak, and then I will see what it is, how the plan will go. I'm sorry, बीच में breakup हो गया तो time मेरा ज़्यादा लग गया, लेकिन we have enough time to have people, and I'm quite audible. So Jack, please come and say greetings to everybody who are dignitaries here, and then you start your talk. He's a senior intensivist, like I told you, past president of ACC, which is the largest body of the world of cardiologists. So he has a huge experience. He's himself an intensivist and cardiologist. Please, Jack, please introduce further.
Thank you very much, Vivek. I'm honored to be with you today, and I want to just say to begin with that you don't want to copy America if you're trying to respond to COVID. We have not done a great job. Unfortunately, in Washington, our president has not been a leader. He has continuously denied the importance of this virus. So it's been left up to the states, the 50 states and their governors, to try to manage the disease. I'm here in New York City, in Manhattan. And as you know, Manhattan was the most significantly affected place in New York City and New York State. And that's because there are millions of international visitors to New York. And so, and the city is very densely populated. India has some of the same kind of population density problems to deal with. But New York got the virus from Europe mostly. And the hospitals were soon overwhelmed. We didn't have enough PPE, protective equipment. We didn't have the number of ventilators we needed. Even by converting all of the acute care beds to COVID beds and trying to keep just a small number for labor and delivery and essential surgery, we still were overwhelmed. And you know, what's amazing in New York is that with the leadership of Governor Cuomo here in New York, people really did come together, and we wore masks. People did practice social distancing. The community really pulled together, and you know, while we were having 8,000 deaths, 8,000 new cases a day, and almost up to 1,000 deaths per day at the peak. New York in the last couple of days has had no deaths and only very, very few new infection cases. And that's because we have really practiced the public health measures strictly. And I can't emphasize that enough, because governors in other states in America, Arizona, Texas, Florida, and other states, have decided it wasn't a big problem. And now they have severe infection rates. So in the U.S., while in the state of New York, we have really controlled the infection, same with the state of New Jersey and Connecticut, our adjoining states, the rest of America is now continuing to suffer an increase in the virus. And in fact, yesterday was the highest day in terms of number of new cases for the United States. So the performance in the United States varies significantly state by state based on leadership. We need, as physicians, to exert the kind of leadership necessary to prevent this pandemic from wreaking more havoc than is necessary. I have to say that in New York, because of the high frequency of infection, and because of the intensity of the initial infection, almost 50% of the people in the boroughs of New York, Brooklyn, the Bronx, and Queens, have immunity. They have antibodies. We don't know how long the immunity lasts, but that's how many people were exposed to the virus. Certainly most of those people were asymptomatic, but nonetheless, a large part of the population of New York was exposed. If you take the entire city of New York, it's about between 22 and 25% of people have antibodies now and were exposed. Certainly, most of those people were asymptomatic and did not go to the hospital. So as we know, I mean, SARS is, and COVID-2, C19, whatever we're going to call it, is a single-stranded enveloped RNA virus. We have learned that even though it attaches to the ACE2 receptors, there does not appear to be any problem with patients who take ACE or ARB medications, and they do not seem to become infected more often, nor do they have any more severe infection. But we are aware that the acute respiratory syndrome of COVID-19 is most likely fatal when a cytokine storm occurs after about a week of infection. And I'll talk more about that later, but that's been the greatest problem for us. I want to talk a little bit about cardiovascular disease and COVID as well. Questions for us about prevention. Is there a genetic risk? I mean, why do some people get so sick and others seemingly not sick at all? We don't know the answer to that, really. We do know that people with blood type A are more likely to be sick and infected than those with other blood types. We do know that people who have a deficiency of vitamin D are more likely to be severely infected. Vitamin D isn't a treatment, but a deficiency of vitamin D is a very serious problem in terms of risk. We also know that people with pre-existing conditions, and particularly cardiovascular disease, have poor outcomes. So, we'll talk more about that. In the United States, we've seen that obesity is a risk factor, as well as cardiovascular disease, as well as hypertension, as well as obviously COPD and pre-existing pulmonary problems. Nonetheless, we're very concerned about the cardiovascular side because patients often present in this country with cardiogenic shock or a myocardial infarction or myocarditis even. The other problem that we've experienced and has been seen elsewhere in the world is the coagulopathy associated with COVID-19, with venous thromboembolism and stroke-like events. This problem has been observed mainly in younger people and people without pre-existing conditions, and so we're very concerned. In the United States, I would highly recommend that anyone that comes in with COVID have a troponin level measured, because an increased troponin is obviously a risk factor. We've seen people with cardiovascular disease in the US, mainly acute coronary syndrome, but we also have seen STEMI. In the case of STEMI, we've decided that it's advantageous protecting the health staff, but also for the patient's well-being, to not to consider PCI and to consider going back to our previous therapies and to look at anticoagulation as and also just to consider our former approaches, because PCI itself hasn't really produced a better result in most patients in the U.S. We've still been doing PCI, but we're now going back to using thrombolytics as a major approach and a better approach and a safer approach for health staff for MI. Acute heart failure has presented in more than 20% of people with cardiovascular disease in the US. Some have severe cardiomyopathy. The cardiomyopathy seems to be divided between people who have direct viral inflammation of the myocardium and those who had cardiomyopathy that relates to the underlying cytokine storm and inflammatory process. So we have to look carefully in terms of what we're dealing with. We have seen dysrhythmias in many patients, and so the cardiovascular side of this disease has to be considered as a serious problem. And I think in cardiology and medicine, we have a large role to play here in terms of helping patients survive, because those who come in with cardiovascular risks are the most likely to die. I'd like to talk a little bit about the therapeutics of what we've learned. We've benefited from a number of studies that show that remdesivir actually reduces the length of hospitalization and the severity of the illness, but it's not a magic bullet. Hydroxychloroquine was used extensively in New York in the early part of the infection. We really didn't show any benefit for hospitalized patients. We do not know about the prevention characteristics of hydroxychloroquine because that hasn't been studied very well. But we don't think that it has a benefit for hospitalized patients. There's been extensive use of interferon and ribavirin and the typical antiviral therapies that we're familiar with. And there may be some benefit, but it's not apparent. And again, for as mentioned by Vivek, tocilizumab and prednisone have been used to try to counter the cytokine storm in the patients for whom that occurs, to just decrease the total body inflammatory response. Recently, we have participated with researchers in the UK, and we believe that dexamethasone is actually the best therapeutic response at the present time for cytokine storm. So this is kind of a new thinking. And for people who have a risk of thrombolytics, thrombolytic therapy is actually better for STEMI, as I said, rather than PCI because of the thrombolytic propensity of this virus, and microemboli in multiple organ systems may exist. So thrombolytic therapy is apparently better. We've also learned that there's a concern, and much more research needs to be done, that once a patient is put on a ventilator, that in fact their condition may worsen, and they may never get off the ventilator. Only 5% of people who have been placed on ventilators in the U.S. have been discharged and successfully, and many of them have long-lasting other problems. So we're worried about that, and we've been starting to use high oxygen therapy with proning of the patient to improve their respiratory status. And so this is now becoming the treatment of choice in the U.S. with better results than we've seen with ventilators. Some patients require a ventilator. That's just the way we're going. But we're thinking that if you can avoid the ventilator, that's a better way to approach this. We know that asymptomatic infection is a huge problem. Obviously in New York City, where some of the regions in New York have 50% of the population already have been exposed, but we're never sick. We're not sure how extensively asymptomatic people actually are contagious and transfer the virus to other people. But we believe that asymptomatic people are a source of infection. So frequent testing is critically important. In the US, the testing lagged behind because the CDC, in its first attempt to develop a national approach for testing, had a contaminated test process that was ineffective. So we spent a whole month trying to catch up with testing in the US, and that's been part of our problem. But the main problem in the US is not testing or therapeutics or even the cardiovascular risk factors. The main problem is the ignorance of some leaders in some of the states in the US who have failed to really recommend and insist that people wear masks, provide social distancing, and public health measures. In the future, there is likely, if we look at other coronaviruses, it's likely that we'll have a second wave of COVID-19 in the fall of this year. But what we see now in the US is not a second wave. What we see in China is not a second wave. It's the first wave that hasn't really reached all the people who were vulnerable. So we're not seeing a second wave. This is the failure to really treat the first wave effectively. We cannot relax public health measures as we see in the United States without having a large increase in the number of sick people and hospitalizations and overwhelm the healthcare system. In terms of treatment, we really, don't have anything magic. So prevention is really the strategy that we need. In terms of vaccines, if we think about our experience with coronaviruses in general, it's a mixed bag. It's uncertain because we may develop a vaccine, but like the influenza vaccine that all of us are familiar with each year, it's not a perfect vaccine. It may attenuate symptoms of the virus. It doesn't eradicate the virus. We're likely to have this virus around with us for some time. until true herd immunity is achieved around the world. The use of plasma of COVID positive plasma is now being studied in the U.S. And while it looks like there may be some benefit to it, once again, I have to say, no magic bullet. We have to use public health means to prevent this disease if we want it to really be under control. Currently, the PCR test obviously is the test of choice for diagnosing, but the antibody tests are increasingly being used to understand where the virus is, where the virus is spreading. Soon, we hope to have a CRISPR test that will be very, very cheap, maybe less than $5 for the test. We'll have both an antibody and an antigen version of CRISPR, hopefully available in a month or two. And these tests could be very helpful because we can have instant results. So imagine this: before you get on a plane, instead of everybody wearing a mask, having people sit far apart and so forth, we should be getting on the plane where we have a 99.99% certainty that no one is infected on the flight. If somebody was foolish enough to get on a ship, a cruise, the cruise ought to be controlled with testing to the point that no one is infected with the virus, and there's no need to wear masks or to be socially distancing because you're safe there. Is this possible? It is possible. It's going to be expensive. It's going to require a lot more testing than we've been doing now, and it's going to require better tests with greater sensitivity and specificity than we have. So that's an important part of the research that's ongoing, as well as vaccines, because the vaccine may really attenuate but not cure this virus, and we don't know yet how that's going to work. All I would say is that in the US now, there's a great political pressure, as there is elsewhere in the world, to get people back to work and to resume our usual productivity. I would say that it's possible to do that, but it's only possible if we do it smartly and safely. And that's with frequent testing, with high quality testing, with daily symptom monitoring, with temperature monitoring, and with a whole variety of public health measures, including expert contact tracing. None of these techniques are being applied, I think, effectively in the United States. I've created a program here called Rebooting America, and we're starting with the Veterans Administration, which treats the veterans of previous wars in the United States. We're hoping to test this out and then actually provide a kind of a rolling research project to see what protocols in terms of testing, contact tracing, symptom tracking, and so forth are most effective. Because there's a lot to learn still. That's the main issue with this virus. We still have a lot to learn. We have learned a lot. It's better if you get COVID now than it was 2 or 3 months ago in the U.S. We're having better results, but it's still a very serious virus, and the fatality rate is still very high. Once again, final point for me: public health measures are the most important thing we can apply. When we do see people with COVID, all of us should be aware cardiovascular disease needs to be diagnosed early because it is a serious risk factor, and we need to manage that in people with COVID. Thank you very much, Vivek.
Thanks, Jack, for a very nice covering the America, and we will talk to you a little later with question answers. I will introduce and take permission from Honorable Santhosh, although you were supposed to, but Dr. ML Gupta, who is a very 85-year-old, he has done a lot of research. If you allow me, he will speak for 5 minutes, and then I would like to have your complete deliberation. So if you allow me, I will request Dr. ML Gupta, and let me introduce him. He is a 1960 pass out King George Medical College. He worked with ICMR, Indian Council of Medical Research, for 28 years. And he has more than 125 publications, which are still being cited worldwide. So I will request him to start his deliberation, maybe if he's ready or not, or maybe let me talk to him. He will just tell about how the clinical trials should be made, and especially in the era when there is no specific medicine which can be done. So repurposed medicines should be done as much as possible. So if he's ready, then I'll take him, or I will take him after Honorable Santhosh. I think they're getting ready. Okay.
Well, dear.
Okay.
Hello.
Yes, we are listening, but you speak. Start.
Am I audible?
Yes, perfectly all right.
I am Dr. Atul Gupta. Age more than 84 years. I did MD Pharmacology in 1963 from King George Medical College, Lucknow. And before I did MD Pharmacology, I joined the Indian Council of Medical Research because I was very much interested in conducting medical research. And I conducted research throughout my life till my retirement from Indian Council of Medical Research. During my tenure in ICMR, I published more than 100 research papers, mostly in foreign prestigious journals of the world. And these research papers published 40-50 years ago are still being cited in the world medical literature by medical scientists. Today, among the area of research that I have done covers many medical topics such as psychiatry, plant medicine, or reproductive medicine, anti-fertility drugs, blood pressure control, and other things, and also cancer research. In cancer research, we for the first time saw that Britannia somnifera, which is popularly known as ashwagandha, was found to prevent chemically induced cancer in lungs in albino mice. That chemically induced cancer was induced by urethane, and those mice which were fed with urethane plus ashwagandha did not develop any cancer in their lungs. This was for the first time that we shown that ashwagandha is effective in preventing cancer by a chemical. And this work is still being cited. Recently, today I have found that Google Alert has sent me information that my research paper have been cited in Nutrition and book published by Mehta, Vikram Mehta, Harish Chandar, and Anjali Munshi. So this work, we found also the mechanism of this ashwagandha that it enhances the leukocyte concentration in the blood, whereas those mice which were fed with urethane did not. There was reduced reaction in the leukocyte count, and those mice which were fed with ashwagandha or Britannia somnifera, their leukocyte count was significantly raised. So that was enhancement of the immunity by which this might be preventing cancer. And I have recommended that the clinical trials should be conducted in cancer patients about the beneficial effects of ashwagandha. It may be effective, and I have in my clinical practice after retirement, I have recommended this drug and given to many cancer patients who were on chemotherapy and radiotherapy, and they got relief from their side effects by chemotherapy and radiotherapy, and they were very happy. So this drug should be tried in that. Now coming on to the COVID-19, I have few drugs in my mind that may be effective in curing or reducing the symptoms of COVID-19. These drugs are very safe, are being used for the last 60-70 years in the treatment of other diseases, and have very short half-life. These drugs increase the leukocyte count in the blood by within 2 to 4 days, and that lasts longer. So that should be tried in COVID-19 patients. Either the drugs seem to either reduce the severity of the disease, thus preventing mortality, or may even cure the disease in a very short time, thus reducing morbidity and time taken for recovery. So I have suggested this drug to Government of India for conducting a clinical trial, and Government of Uttar Pradesh also, that this drug should be tried in a few cases so that to find out whether the drug has any efficacy or not. The best thing is about this drug is it's very safe and seems, and if found effective, it would be a boon. The present problem is to find a drug. The present problem is not to find a vaccine. Vaccine will take time, and vaccine cannot be given to patients suffering from COVID-19. They have to be treated with a drug that should be effective. So I have few drugs in my mind. They should be effective if tried clinically in few cases, and when they are found. The advantage with the old drug is that we don't have to do any toxicity study, we don't have to find out the doses, and the drug can safely be given without any side effect. So it will save time, and further, in a country like India, the drug is very, very economical. They are priced very low priced. So treatment will be less costly. This drug, if found effective, may also be tried for a prophylactic value. It may prevent the development of the disease in those contracted cases who might develop COVID-19 later on. So that's all. Thank you very much.
Thank you very much. Let me introduce further. He's my father. And under his leadership and guidance, I have been able to do such a work, and I've topped all through in UP, PMT. I was the first attempt and topped also. So the drug which he is proposing is already sent to the Government of India and Government of Uttar Pradesh. The clinical trial is only 14 days. He's not forgotten to tell, he's forgotten to tell. 14 days trial for 20 patients each. And if it is found to be effective, it will be very, very useful for the whole country. So we'll look forward for that approval later on. Before yes, Madhvi Agarwal ji, let me introduce you, and she has been waiting from Calcutta. So now she is basically from West Bengal and BJP media spokesperson. So I have now the privilege of having our chief guest to start his deliberation. But now I will be introducing him formally. He's let me talk to him. He's a social worker, politician from Bharatiya Janata Party. Jack, are you listening? He's a social, and he's also a member of Rashtriya Swayamsevak Sangh, currently serving as General Secretary organization of the party and the second most important office within BJP from July 2009. Yes. He has worked as a General Secretary organization for 8 years in Karnataka state and was appointed National Joint Secretary in charge of Southern states in 2014 by then the President of BJP, Mr. Amit Shah ji. He hails from Karnataka. He studies engineering. He's an engineer and Government BDT College Engineering in Davangadi, Karnataka. He's trained as chemical engineer, as a full-time worker of RSS in 1993. He can fluently speak 5 languages: English, Hindi, Kannada, Tamil, and Tulu. He has been inspired so much by RSS that he has spent his time alone, not married, devoted his life for the Sangh Parivar, and took important roles in the organization. He's a highly intelligent person, which I can add from myself. And he has knowledge all through being an engineer. He has a huge background of his overall. So now we look forward to have the deliberation of our Honorable Mr. BL Santhosh ji, how India is preparing, what are the spiritual ways we can look forward to tackle this COVID-19, which is actually a problem, because as a doctor, when I see patients not able to give bed to the patient. Just now, for Sarita, we had somebody called me, I want an ICU bed and oxygen requirement. I had to deny because there was no bed, and no bed also in the Delhi vicinity area. He may be trying to go to some government center, which they were not immediately available. So the things are not easy. And although newspapers sometimes say that things are getting easy, but it's not true. I personally feel that even one death is very important for that family. Even if our death rate is low, that does not mean that we are free from the disease. We have to take care of every patient. So, Honorable Santhosh, I take the pleasure of inviting you for your talk and thought process.
Thank you, Dr. Vivek Gupta, for inviting me for this webinar and giving me an opportunity to address such an august audience. I know very clearly that I am in front of medical experts, medical scientists, medical administrators, and office bearers of the IMA, and also some general enthusiastic persons. As Dr. Vivek Gupta has already mentioned, I am neither a professional nor a scientist. I am a social worker. So whatever I tell today in front, little time, that you have to take me as a social worker, not as an expert or something else. And I am from an organization, so I am not from the government also. But I have my ear on ground, whatever happens as far as the policy is concerned. One thing is for sure, India has managed this crisis better than many other countries. I am not telling this on absolute terms, I am telling it on relative terms. What were the reasons for this better management? Though the absolute numbers that we look on the screen every day in front of us on TV, though the absolute numbers are a little higher, it is around 4.5 lakhs today, with 2.7 lakhs cured and 1.8 lakhs active cases. But if you look at the kind of population that this country has, more than 130 crores, and the size of this country with 8.5 lakh villages, and the kind of health infrastructure that we had before the COVID crisis, if you look at all these things, I think India has managed very well the whole crisis. I have to thank the administrators of this country, right from the union government to the state government to the last person in the civil administration, who have been on a single page. This I want to underline it and tell in front of you. When you compare ourselves to some other free democratic countries, I will not go for opaque administrated countries where the number itself is doubtful. I will only compare our country with the free democracies where the numbers are transparent and the society is open and the government is up for correction or review or whatever it is, like that which happens in India compared to those states. The first and the foremost thing that has been to the advantage of the country, the huge country like India, is our administration, from the Prime Minister to the last person in the administrative setup, they are being on the same page. Lockdown, when it was suggested by the Prime Minister, it was accepted to the last person. Easing down, except for few where they continued for a little more time. Easing down also, relaxation of the lockdown also, it was accepted to the last person. Wherever there was problem, there was conversation, there was dialogue, there was interaction, and through that things were solved. And the hand holding from the union government and also the efficient way of handling by the state government, it has been exemplary as far as it is concerned. We have seen many countries where president is on one page and the governors on their different pages. We have seen many countries, I don't want to name those countries because I'm not criticizing it for, I'm only telling it to compare to the Indian way of handling. We had some other countries where the Prime Minister was on one page, the Health Minister on the second page, and the Supreme Court was on the third page. Compared to all these things, except for some things like some of the conditions or some of the things that were there in the guidelines. Other than that, rest everything, I think India has, as an administration, it has carried well. This is the number one. Number two, the timely interventions the governments at various levels have done. When I tell union government, I'm not here to just eulogize the Prime Minister or carry forward with the flag of my party. I am telling to the last person. India has been one of the best civil administration in recent time during this 100-120 days. One of the best civil administration. The people at the municipality level, they have created their own tracing, contact tracing app. They have created their own quarantine mechanism, their own isolation mechanism, their own health infrastructure, their own system of handling the crisis in along with the social organization. Even at the last, So this hand-holding by the union government and also the perfect reciprocation from the states and the civil administration have seen to it that India is passing through this crisis little more unscathed compared to many other countries. We started with 0 laboratories. Now we have 1,000 laboratories. We started with few hundred tests, and today we are 2.5 lakh around. It is 10,000 less, 10,000 more, but around 2.5 lakhs tests. And we started with 0 and nothing, almost 0 number of testing kits. Today we are slowly becoming independent as far as testing kits are concerned. The health infrastructure, the second point, which was not so good in India compared to Italy, Spain or US or something countries like that, which was not so good, especially in public sector. What was also good was only in private sector. What was not good, it was more so on public sector also. But as of now, 70 to 80% of the patients who are being attended by the public health services, we have seen that even that has also risen to the occasion, and the private sector has also picked in with its cooperative hand, so that the country is managing the things in a very well manner. We had many advantages. As I told the administration, right from top to bottom, it was on a single page. Right kind of interventions at proper timing, like forming the task group on January 8th, starting screening on January 27th, first case on January 30th, then universal screening by February 16th, banning all banning the flight from South Korea, China and some other countries by the end of February, then putting a total block on all the international flights by March 22nd, then stopping the internal flight, the domestic flight too. Then our Janata curfew on March 22nd, which was accepted by every single person in the country. Then our lockdown on March 24th. This is the way the country has progressed from day 1 on January 8th, when it was informed to the country that there is a new virus that is in the horizon. From that day till today, we have managed in a structured manner, in an organized manner, and with a sense of duty right from top to the bottom. Second, we have our own civilizational advantages as far as this virus is concerned, which is absent in many other countries. I want to tell you with pride also, and also with total sense of practical this thing. The kind of lifestyle that we had practiced for centuries together in our country, like the kind of spices that we use in our food item, that in itself has increased our immunity level through generations. Like haldi. Everybody sitting here, we use haldi in our everyday food preparation. And haldi is the best form of natural immunity enhancer, as every doctor here, every scientist here will accept. As Dr. ML Gupta mentioned, ashwagandha. It is in daily usage across the country in many homes where they don't even know the spelling of what doctor means, but they know ashwagandha. They don't know that the doctor is DOCTOR, but they know what ashwagandha is. The Swasari medicine, the Tulsi Kanavati, the kadas or the ingredients of kada, and some of the basic homeopathy medicine which have been in use in the country from times immemorial. They have seen to it that the virus, which have been more lethal in some other country, has been less lethal in India. It has been less lethal in India. Our mortality rate has been just around 3.2%, that too in last 10 or 12 days. Otherwise, it was minus 3%. What was the reason for a virus which is so lethal in US, which is so lethal in Brazil, which was so lethal in UK, Italy and Spain? We are not made of some other materials or DNA which doesn't belong to the ordinary human being, but we had a civilizational advantage as far as that is concerned. And today, almost 50% of the houses in the country, I want to state in front of you, in front of this august audience, with the great sense of responsibility, that almost 50% of the households in this country, they are taking some or the other kinds of local medicine which enhances the immunity level of this individual, which enhances the immunity level of the individual. I myself I used Anutaila, which is a very ordinary medicine in our country. Anutaila. Every single Ayurvedic company, it manufactures Anutaila, which has been suggested by many doctors, many allopathic doctors also, as a preventive thing. I used for 15 days Anutaila, which were nasal drops. And even today, I can tell with practical experience that because of the usage of that Anutaila, now I feel and my nose is more clear as far as respiration is concerned. So these are the civilizational things that we had in our general practices, which may not be termed as medical practices, but which can be termed as life practices. Along with that, the awareness about wearing the face cover, the awareness about social distancing, many sections of the society, and also the increase in the level of the public hygiene across the spectrum, social spectrum, it has seen to it that though the absolute numbers are more, but when you talk about per billion numbers, per billion positive cases, per billion active cases, per billion death cases, or per billion whatever it is, whatever the factor, except the testing cases, where we are enhancing our capacity every day, right? Everything compared to the world, compared to other countries of the world, we are far better placed as far as today. When we talk about 1.8 lakh patients, according to the Ministry of Health and Family Welfare numbers, if I am right, we have less than 3,000 patients in ICU. What was the projection? Some expert came on around February 16th or February 17th on many of the news channels across our country. I don't want to name him. But that expert told that by the end of May, there will be 3 million cases in the country. 3 million cases. And we were wondering what will happen to the country with such a meager health services if there are the 3 million cases. And today we sit here, we have assembled here on June 25th. We are sitting today on June 25th, which is not even 0.3 million also, let alone 3 million. We don't have cases with 0.3 million also. And I tell you here, we are an open democracy. We are up for public scrutiny. Wherever there was mistake in numbers also, our open democracy and our public scrutiny has seen to it that the Maharashtra government and the Mumbai administration had to readjust this death figure to plus 900 around 15 days back. Plus 250 death number in Delhi. So it is up for public scrutiny. In spite of all this public scrutiny, we are nowhere near to 3 million, let alone 3 million. We are only 0.3 million as of today. We are only 0.3 million as of today. So this is the condition of the crisis as far as India is concerned. But even this 0.3 million, I am not telling that we are off the danger radar. We are off the problem radar. We are very much in the crossfire of the problem. But for that, our health services and also the government and in general the society, except for a section of the society which doesn't understand. Being sympathetic to them, I tell you frankly that they doesn't understand the seriousness of the situation. Barring that section of the society which doesn't understand the seriousness of this problem, I can tell you in front of you, the Easter, which is the biggest festival for Christians outside Christmas, it was totally celebrated in homes by the Christians in this country. Number one. Number two, Yugadi, which is the starting of the year for across the spectrum Hindus in this country. It was celebrated in individual homes. Nobody went to temples in this country. The whole month of Ramjan and celebration of Eid by a large section of the society, which was practiced by the society Muslim, is that also, except for few stray incidents, which are less than 10, I can tell, across the country, less than 10. Except for stray incidents. The Ramjan, Eid, it was also celebrated in homes only. Buddha Jayanti, biggest festival for people who are the followers of Buddhism, that also came during lockdown. That was also celebrated in the homes itself. Nobody went to Chaitya. And the Mahavir Jayanti, which is the biggest festival for Jains also, they also didn't go to any mandir. They also celebrated inside the house itself. This is the level of responsibility that the society, Indian society, has exhibited in this period of crisis. Hindus celebrated their Yugadi in their home, Muslims celebrated their Ramjan and Eid in home, Christians celebrated their Easter in their home, Buddhists celebrated their Buddha Jayanti in home, Jains celebrated their Mahavir Jayanti, compared to this, many in Western societies, they are not even ready to let go their vacation on seashores. They are not even ready to let go their vacation. And we have seen many of the countries on Mother's Day, they were celebrating as if they were not in the midst of any crisis at all. The crisis at all. Compared to this, the Indian society has behaved much maturely, which was unexpected by this society. It was unexpected by this society. The biggest advantages out of this crisis is India has enhanced its health services level to somewhat a moderately good level compared to the exterior, to a moderately good level. Now the number of ventilators that we have, the number of scientists who are working on testing kits, the number of institutions who are working on our vaccines, the number of startups who are engaged with the big manufacturing houses to create medical infrastructure, the doctors, the ethical behavior with which the health staff in this country has behaved, the ethical behavior of the health staff, it is something wonderful. It is something wonderful. The risk they have taken inside the isolation wards, the risk semi-trained health staff across the country who are going on the screening drive across the country, the municipal staff with barely minimum training, the way they are exhibiting their sense of duty, it has been something heartwarming as far as this country is concerned, as far as this society is concerned. Yes, we are facing a big problem even today. Many experts in the field, many doctors are telling we have not yet peaked. Yes, we are about to peak. The good thing is that many states which had huge problems like Rajasthan, Madhya Pradesh, Gujarat, they're stagnating now. Cities like Mumbai, they are also stagnating now. The biggest slum in the world, Dharavi slum, it is only getting less than 10 cases in the last 7 days. Dharavi is getting only less than 10 cases in last 7 days. Yesterday it was 9. Only one day it was 11. And it is the biggest slum which we were fearing. Except the NCR region in Haryana and Uttar Pradesh are also trouble-free, except for Gurgaon and Faridabad in Haryana and Noida and Ghaziabad in Uttar Pradesh. The Uttar Pradesh is also trouble-free. Together with Bihar, Uttar Pradesh and Bihar, their population is more than the population of 99% of the countries in the world. Together, the total population of Uttar Pradesh and Bihar, it is 99% of the countries across the globe don't have that population at all. But what is the number of cases they have? Together, they are less than 35,000. Together, they are less than 35,000. But their population is more than 35 crores. For a population of 35 crores, they have less than 30,000 population. This has been something great as far as this society is concerned. With our civilizational practices like Namaste, when told that I am Chinese, I am not virus, please hug me. We don't have that hug practice at all. Only in very close quarters or very cordiality, we do hugging. Otherwise, we have our Namaste. Our food practices, which has got life sciences in itself. Life sciences in itself, our food practices, that has also played a big role in it, because of which the immunity level of an average Indian is more than compared to many other societies. And the universal BCG, which many scientists and doctors are accepting also, the universal BCG, that has also been a major reason for India passing through this crisis without much damage to as a country, and also the timely intervention of at all levels of administration, right from the Prime Minister to the last municipality chairman and the administration there. These are the things I think have made this possible. And we are still in danger zone, but the level of preparation and the level of engagement now, whatever we are having in this country, we are hoping that by mid-July, the scientists are also telling by mid-July, we may peak and then we may slow down. And we are approaching the peak, is being experienced by many states. We are approaching the peak, is also being experienced by the stagnation in many major centers like Indore, Ahmedabad, Jaipur. I want to tell you, even Mumbai is also. I am following the numbers. I am not a scientist, I am not a doctor, but I am a social scientist who follow the numbers every day. Major centers are flattening now. Though they may not be decreasing, they are not coming down, but they are flattening. With this, I think we hope to have better news in the coming day, along with whatever the scientists and the doctors who are sitting there with your efforts about finding out the vaccine which will be a permanent solution. Finding out the vaccine which will be a permanent solution. The rest of the things that is inherent in this society and the way the society and the governments have behaved in this country, I think will pass through this crisis without much damage compared to the other countries. Without much damage compared to the other countries. And the country is also opening up. The increase in the number is because of the relaxation also. And relaxation is not unnecessary or uncalled for or unplanned. This relaxation is also necessary. And even with this relaxation, except for Mumbai, Chennai and Delhi, rest of the mega cities have all managed themselves well. Rest of the mega cities have all managed themselves well, except 3 cities, where there also huge interventions have been made by various agencies, so that they also will be contained. And I think now from this point, we have to look forward so that how we can increase our level of immunity of the ordinary person through other major interventions, so that before the vaccine comes, which may take another 6 months or 12 months as the experts are predicting, more credible vaccines, it may come in next 6 months or 12 months, whenever it has to come. Till that, we need to sustain, so that through our immunity intervention, our administrative intervention, and also the kind of service that is being provided by the healthcare professional. With these 3 things in good form, I think the country will pass through this crisis. Thank you.
Thank you very much. Very nice, provocative, I would say, and thoughtful deliberation from Honorable Santhosh. You're not a social person, you are a half scientist, half doctor, or either full doctor, you know everything. And you have been following with such a diligence, Jack will agree, that we have learned many things which I was personally not aware as far as state-wise concerned. So this is actually a positive thought process which he has given. That means we have not done bad as such. We have done the best. Although such a huge country with 137 crore population, we have managed it well under the leadership of Honorable Prime Minister Narendra Modi ji, and of course Mr. BL Santhosh ji. He's behind the camera, but he's working very hard to see that everything is implemented. I will request Honorable BL Santhosh ji to stay back, because there are very important few deliberations which will be limited deliberations only. I would request you to listen to them. So I will invite now my friend, Mr. Dr. Hakim from Nigeria. He's actually a medical interventional cardiologist and head of Katsina Medical Center for Medical Research, and he will tell what the problems Nigeria is facing. And Dr. Hakim, can you please unmute yourself, because I'm trying to unmute you. Yes, okay. So you can please start your deliberation. And Nigeria as a country is the largest country of African region, but they're having problems. Although numbers are not too high, but testing rate is too low. So Hakim will tell what more is there which I do not know.
Hello.
Yes. Please go ahead. Something is wrong there. Dr. Hakim, are you listening to me? Maybe we can take him a little later. So I will request now in the row to have our...
Hello.
Yeah.
Hello.
Yeah, okay. Go ahead. Unmute yourself.
Hello.
Yes. Perfectly. You are
loud
and clear. Please go ahead.
Hello.
Yes. Are you listening to me? I think
hello.
Yeah. Hello. Please go ahead.
Hello. Can you hear me?
Yes. Perfect.
Hello. Can you hear me, please?
Yes. Go ahead.
Okay. Sorry, I cannot hear you. But
okay,
can I go on?
Yes.
Okay. Thank you very much, everybody. I hope I'm clear. I'm loud. But thank you very much. I'm Dr. Hakim, speaking from Nigeria. Sorry, you may have some few issues with my network here. It's my pleasure sharing our experience in Nigeria about COVID. And I want to thank the earlier speakers. We share so many factors together, as what we have in Nigeria. But Nigeria is really a very painful picture of what COVID and the health care delivery in Nigeria is all about. I will be speaking from personal experience as being one of the survivors of COVID in Nigeria and what is obtained in Nigeria. I must say, if you ask me what is the greatest need in Nigeria, I think we have to get over belief, a lot of disbelief. A lot of people, I mean, the great majority of the population of Nigeria still do not believe in COVID. And it's so pathetic that I've listened to the prof that spoke from America and our very respected social worker, and I can see some of what you have lined up in fighting COVID. We don't have in Nigeria. If I will share one of those things, you don't have remdesivir in Nigeria. You have few ventilators, whether they are useful or not in Nigeria. You cannot get any center that can do plasmapheresis in Nigeria. And then people are totally indifferent. Now, let me talk about what is going on in Nigeria. Nigeria is as complex as COVID itself. It's an admixture of so many tribes and religions. And it's a very vast country of more than 200 million people. Now, when we had an outbreak in Lagos, which is the commercial center of Nigeria, the structure in Nigeria is that the federal government in Nigeria quickly intervened and supported that state and giving them huge amount of money. And the other states were not happy about that. Now, if you look at currently, we have close to 22,000 confirmed cases in Nigeria with about 500 deaths. So we have a fatality rate of about 4% in Nigeria. Now, if you look at the trend, you will see in northern states, every day they report 1 or 2 serious underreporting of what is going on. Whereas in Lagos, you got a lot of reports of people coming up and they will say it's just justification to spend what has been budgeted for them. Now, if you look at the greater picture, is it true, if you look at northern states, is it true we don't have cases? I don't think it's true. Recently, we have mysterious death. Now, if you bury 2-3 people in a day and suddenly you are burying 50, 60, 100 in some northern states. And unfortunately, in where I practice, autopsies are not what you do regularly because of religious belief. Very few autopsies are done. So we did verbal autopsy, and the report would have it that close to 50-60% of patients probably died of COVID. Unfortunately, the public administrators, they came around and said, no, 10%, 15%. We still have that in Nigeria. And if you come back to Nigeria, it's a very, very painful picture where I practice. There is total disdain. People just move around as if COVID does not exist. Hand washing, face masks, nobody respects anything. And just like if you follow the trend in Nigeria, the majority of healthcare in Nigeria is run by public rather than private. Just 2-3 days ago, private doctors just resumed. They were on strike. No personal protection, nothing to work with. I contracted COVID in line of duty. But what I want to say is that, yes, if you go back to specific in subspecialties about what we have, we don't have a center-wide collation of what is really going on in Nigeria. Of what is going on in Nigeria, you find out that, yes, diagnosis, we use PCR. PCR is about 10,000 Nigerian naira, about probably $50-60. And average ANA in Nigeria gets less than $1 in a day. So most governments in Nigeria, the state government, they don't want to take responsibilities. So we are not testing in Nigeria. So if you are not testing, are we really flattening the curve? I think it's not the truth. So if you don't test, you don't make diagnosis. Unfortunately, many patients that have been tested and positive are allowed to roam around in the country. They tell you should go and self-isolate at home. The Nigerian structure, the Nigerian own system is not the one that supports self-isolation. So you have patients that are positive moving around and it keeps spreading, and we are now sitting on a time bomb. Now, what of patients that we have managed? Unfortunately, we are trying to collate in all the various societies, cardiological society, nephrological society, to see if we can have good data that we can share with our colleagues outside. Some of our patients, especially respected patient doctors that have died, quite young, 35, 40-year-old, they came with very severe storm, with hypoxemia, with loss of consciousness. And I must say 2 of them had to be dialyzed. We did dialysis. Unfortunately, we may not have nephrologists in the house. In Nigeria, what you have only conventional hemodialysis, and we don't know whether certain mode of dialysis will be better. The patient that had conventional hemodialysis, unfortunately, all of them died. Now, for the cardiac cases that we found there, I'm happy with what the prof said from America. You don't have PC high readily available in Nigeria, a few centers, but we can have thrombolysis in Nigeria. Now, some of our young or probably young patients that came bizarrely, patient without any medical history came with severe myocarditis, with unfortunately again, a few of them we could not go beyond that because many of them did not have echo. They at best had ECG and chest X-ray with massively dilated heart. Unfortunately, they succumbed and they died. Now, our problem in Nigeria is compounded by very high level hepatitis B prevalence. And most of the patients, they come actually bleeding. You find whether they have a DIC. So you have a dilemma. A few that had thromboembolism confirmed by D-dimer tests and pulmonary angio, you are at a dilemma of what to do because they were bleeding actively. We tried to correct the bleeding, giving them fresh frozen plasma, giving them other concentrates. Unfortunately, most of the time we have very, very tight. Remember, healthcare in Nigeria, you have to bear it out of pocket. So if you look at the records in Nigeria, cardiovascular complications are probably very, very high. And I must say, second to that is nephrology in terms of acute kidney injury or acute on chronic for those with pre-existing disease. We have quite young patients that have died between 30, 40. We've had a miracle, about 80-year-old that survived. I must say in our practice, we don't use ventilator. Of course, we don't have ventilators. But what we do in Nigeria, most of our patients, they get other pulmonary support. We do CPAP, we do PPAP, and they come around. And recently, we have asymptomatic patients. Many patients are asymptomatic, and we've not been recording mortalities. I don't know whether it's from immunity. The prof just said hard immunity may not be a problem. That was what we are thinking Nigeria might be the result where they're getting well. But I must say, we work in a very difficult terrain in Nigeria. I didn't get remdesivir. I didn't get any of the monoclonals. I used probably zinc, and we used antiretroviral and we could our hands on. And that was that we used a protease inhibitor and with zinc, with other support. But I must also say what the social worker did say, very, very useful. Local Indian remedy, ginger, aloe vera, what people use majorly in Nigeria. And they have been found, of course, without proof to be very, very useful. So I must say it's difficult for you to get reports from Nigeria now. We are still doing countrywide collation of data. And I'm quite sure, I'm sorry, my network may not be very, very good in Nigeria, but I hope I've been able to make 1 or 2 deliveries. So thank you very much, Prof. Thank you very much.
Thank you, Hakeem. You were very well audible, and you did a very good job. But it's a very pity and unfortunate that the country like Nigeria, which is the largest Africa, as you said, 200 million. I mean, you don't have plasma therapy, you don't have remdesivir, you don't have favipiravir, you have no ventilators, you have just non-invasive ventilator. You suffered from COVID-19. God was great that you come out of it. So we applied for a joint research grant, as you said. Maybe we can work together for future. So in the sequence, thank you. I'm now inviting, and I'm again thankful to Honorable BL Santhosh to stay back, and we have Mr. Atul Garg, and then before that, I will invite the Cardiological Society of India President, Mr. Milan Kantidas, to please come and unmute himself so that we can hear him very well. And let me introduce, he's one of the senior most interventional cardiologists. He hails from Kolkata. He is a president of present Cardiological Society of India, and he has been working in hospitals, and he has been associated with CSI for a long period now. So please go ahead with what CSI and what otherwise West Bengal or otherwise, what is your thought process in COVID-19? Although we have learned a lot from Honorable Mr. BL Santhosh regarding the state-wise structure. We know medically, but the state-wise, he's told very well that the things are not that gloomy. Things are not that gloomy. That's a very good point, and we have to be positive. Please go ahead.
Good evening and good morning to everyone. I'm really thankful to Dr. Vivek Gupta and his team for giving me the opportunity to speak in this front. Am I audible, Dr. Gupta?
Perfect, perfect.
Okay, so
loud and clear.
For giving me the opportunity to speak in front of this learned gathering all over the world. And it's very encouraging that Mr. Santhosh Santhoshji has come over here to inspire the people that really we are going in the right direction. In fact, I was in the video conferencing with our Prime Minister before the lockdown was declared in India. In fact, this was a shock treatment to all the people in our country, and this treatment actually changed the fate of our country in terms of controlling the the COVID scenario in the most effective way that has been possible. How cardiology actually has come to the focus of this kind of contagious disease, that is an infective disease, because of the fact that all the statistics that have been delivered from Yuan and other parts of China is they showed that the cardiovascular disease, hypertension, diabetes mellitus, all these were having more of chances of having mortality and morbidity due to the COVID disease. But at the same time, what has also transpired over a period of time, we have now already crossed a long time, say 150 days or so for the whole world after the explosion of the COVID bomb has been there. And we have ourselves in India crossed about 95 days. And we have seen, though the disease is very contagious, but it has not really caused that much of mortality. Now, there are so many statistical aspects of the disease itself, though literally we have got 5 lakh persons being infected. These are tested cases, mind you. There is a group of patients who are untested. I am not speaking about the asymptomatic patients, they are untested. And according to the epidemiologists, we might be having to the tune of, say, 10 to 20 crore people who are already infected. Say, for example, I am actually with the COVID war from the very beginning. I have not been tested. It means, it doesn't mean actually that I am not infected, though I am not having any sign or symptom or any kind of feature. So that is one story. And second part of the story is that it has been controlled in a very much successful way, as Mr. Santhosh actually highlighted. We were always discussing as the cardiologists that the non-communicable diseases are surpassing the communicable disease. Suddenly this kind of communicable disease actually surfaced in our country. We are not really prepared. But at the same time, our common knowledge, our common perception gave us the clue. In fact, there is a sort of common term used in the surgical parlance that whenever there is a fire inside the home or fire in the home, so you take the valuables and flee away. Take the valuables and flee away. And here the basic principle was to follow the basic norms of prevention of infectious disease and not at all the therapeutic aspect. Therapeutic aspects will be taken care of by all the specialists, we being the intensivist along with the cardiological practice. So we know how to manage the cardiac arrest, we know how to manage cardiac failure, we know how to manage heart attack and all, but we didn't deviate from the basic principle of infection. Our community, whether it is the cardiologists or non-cardiologists, did not the infection principle. So all the measures that were advocated from the advisories from time to time were taken into account, like social distancing, using the mask, using the shield, then putting on the gloves, putting on the caps, and the PPE, and all these things were being followed ritually. Now, second thing, what from Cardiological Society of India we could do after the appeal of PM to the general population, we contributed actually liberally to the PM Cares Fund so that he can actually take the small paltry, whatever we contributed, and summed up with the other contributions and face the challenges that are being bestowed upon with the COVID scenario. So apart from that, actually Cardiological Society of India has given various guidance to the fraternity, like we gave guidance how to manage an infarction. As Dr. Lewin as Dr. Lewin has beautifully said, that they are now following the principle of fibrinolytic therapy, that is the block blaster, which are basically pharmacological agents. From the very beginning, because of our heterogeneity in the geography, heterogeneity in the income, heterogeneity of our facilities, logistics, we recommended more of the pharmacological treatment rather than the the invasive treatment. We advocated invasive treatment only in those cases where there was failed thrombolysis, where it was a scenario of instability. So there we recommended that the PCI should be continued. Otherwise, in unstable or unstable patient, we thought that it will be prudent to go ahead with the conservative management. Similarly, we also gave the guidance on heart failure. We also gave on how to do the echocardiography test and how to avoid most of the tests, because it's not very much urgent to do all the tests. If you minimize the test, you are actually minimizing the chance of infection. So that those kind of things were done from the very beginning. Similarly, on hypertension also, ACE inhibitors were recommended to be continued. So we gave the guideline. At the same time, we thought that it would be very useful to use the digital technology, and thereby we brought all the presidents who are living now of Cardiological Society of India. Almost 24 presidents came to the forum, to the platform, and they advised the doctors, inspired the patients that nothing to be feared of corona. You stay cool, you follow the norms, advisories of the government and other regulatory bodies. You will be coming out of the COVID bombing phenomenon. So that actually helped, and now we are going to actually to all the patients. It will be focused to all the patients through FM channels. Our doctors, colleagues, they will be giving the assurance to the patients that we are ready to actually give them the best safe methods, because we have started the the clinics and all. We are following all the norms of social distancing, then sanitization of the hands, using the gloves and all, so that everyone is safe. So Cardiological Society of India is trying its best to be living with the new challenges. And I know as per the epidemiologists, this is going to be there for quite some time, maybe years, and we'll have to live with it, and we'll have to follow the rules. And then only if we follow the rules, if we follow the basic principles, then definitely we'll be in a better position to combat the diseases, not only in the form of COVID scenario, for any other infectious disease which will be trying to blow us or flatten us. So with these few words, I thank all of you for listening to me, and also to Dr. Vivek Gupta, who has really beautifully organized this kind of meetings for the benefit of the people. Thank you.
Thank you, Dr. Das. As usual, you have spoken quite a bit about CSI as well. Yourself has a nice and noble soul that you are working very hard. I also gave a small bite on the FM to give a more of a sort of a advice to the patient and tell them that we are COVID safe. A lot of heart patients are not fearing to come to Apollo or any other hospital, and they're trying to subside the angina. Okay, give some medicines on the video call, and sometimes the mortality can happen. So this is very important, because non-COVID patients are really fearing to go to any hospital. Even if it's required, they are not able to do ECG, so, and sometimes the people, they actually really collapse at home. So this is a good thing from CSI to, on 1st July, I think it will be there. Myself also, I was given on FM on behalf of CSI. So I request, moving on to the next, Mr. Atul Garg. I think he's busy on phone. He's a State Health Minister of Government of Uttar Pradesh. I think he just missed that he will be. So may I go to the, maybe I change the sequence. So the next in the sequence would be, if he's finishing the phone or, okay. So let us go to the next sequence, which will be Anshu Anand. She is actually a healthcare business advisor. So in the present scenario, the hospitals are suffering. In the present scenario, as I work in the Apollo Hospital, and I know that most of the small nursing homes are not able to sustain. And just because, and the new hospitals planning, which personally I also have to develop into European hospitals, they are getting at the backstage. So she will advise us whether it is right time and how the hospital can sustain. In just a few 5 minutes she will take, and then I'll get back to the Honorable Health Minister of Uttar Pradesh. Anshu, please go ahead.
Sure. Thank you. So we have seen unprecedented pressure on the healthcare system in the current pandemic, and this has put triple burden, of resources on the system, on the whole sector, with very low financial performance, with less than 80%, with up to 80% fall in the revenue. So now, I think going forward, the goal should be to have a systematic change in the healthcare sector, which has to involve software-based solutions. The government of India has the world's largest funded healthcare scheme called Ayushman Bharat, which has, by May 2020, it has reached more than 1 crore beneficiaries. But the main issue of primary healthcare being achieved by everyone can only be done when there is AI-based primary healthcare that is delivered at home continuously and comprehensively. Besides that, we need to think as a healthcare sector for the incorporation of technology in the business functions. What it does is there is still some disturbance. Okay.
I'm muting all, and then I'll unmute you.
Sure.
Okay. Okay.
Yes, thank you. So with the current crisis that healthcare sector is going through, I think it puts emphasis on the intelligent way of looking at operations of the business function of a healthcare system. Now that means enabling software-based solutions. There can be real-time data that enables a faster reaction to addressing any queries or incoming issues that the hospitals may face. And also, of course, like current issue is the footfall that has reduced in all the other departments, which can also be addressed when there is a AI-based approach, and the emphasis has to be made to provide primary healthcare at home. And besides, I think the SOPs of the business of healthcare, systematic way of operating the processes need to be aligned with a certain disaster management agenda. Considering this may not be the only pandemic that the world is facing, there may be similar or something more severe in nature that may come. So I would, and besides, in terms of in terms of the investors' sentiment, I see the healthcare sector last year up to July had seen 155% growth in the merger and acquisition, which means most of the healthcare sector got over $1 billion in funding in India. Going forward, I can tell that I think in the next financial year, among all of the merger and acquisition, more than 70% will be done in healthcare sector, because there is a dire need of these solutions to reach out to the entire Indian population. And I think we can benefit with self-reliance that the government is focusing on, that could give rise to the export of overall healthcare arms. So that's it, from me for the comments on the business.
Thank you, Anshu. Very nice comments. That means investors should be still proactive to start new ventures in India.
Yes, they are. Indian and foreign investors.
That's a very positive point, in fact. So I now request Mr. Atul Garg in the sequence, and then we'll have Dr. Girish Tyagi, who is the president of DMA, and then we'll have Dr. Subhash Chandra from Agra, and then Charvi, Jain, and PK Asokan and Yashpaul Sharma. Yashpaul, I'm keeping you at the end. People will love to listen to you. So, but I will request again, Honorable Mr. Santhosh and other dignitaries to stay back till the end. We are trying to finish by, it's already 8:45. So I think we have to rush up the things. I did not see the. So Mr. Atul Garg, let me read out his biography. He is an Indian politician from Ghaziabad who is a Minister of State in the government of Uttar Pradesh. He is a member of Uttar Pradesh Legislative Assembly representing the Ghaziabad Assembly. He has been a member of BJP for a long time. He campaigned for Uttar Pradesh Legislative Assembly election 2012. But following the 2017 election, he joined the Assembly. He is the Minister of State responsible for food and civil supplies. I think now you are the health. And let me tell you that he's a promoter of entrepreneurship, education, engineering, and management colleges in Uttar Pradesh. Through various colleges, he's been promoting trainings in entrepreneurship and skill development. That's very nice of you. Mr. Jai Pratap Singh Ji, the Cabinet Minister of Uttar Pradesh Health, was in the last webinar. So he spoke a lot about the health. I just want you to focus a little more about Uttar Pradesh, how it is going to fare up the crisis under the leadership of Honorable Chief Minister, Mr. Yogi Adityanath Ji.
First of all, I will like to thank you. आपने मेरे लीडर श्री संतोष जी को मेरे को सुनने का मौका दिया. इतने बड़े-बड़े जो विद्वान लोग हैं पूरे देश और दुनिया के, उन सबको भी सुनने का मौका मिला. और कोई बात ऐसी है नहीं कि जो मेरे नेता ने नहीं कही हो. सारी बात पूरे देश के बारे में आपके सामने रखी है. लेकिन उत्तर प्रदेश के बारे में मैं ये बता दूं आपको कि न केवल हम लोग यहाँ पर हमारे मुख्यमंत्री कोविड के लिए लड़ाई लड़ रहे हैं हम सब लोग मिलके, बल्कि 36 लाख लोग, मतलब अबाउट 4 मिलियन जितने भी हमारे माइग्रेंट्स थे, हमारे जो मजदूर भाई थे, उनको हम लेकर के उत्तर प्रदेश में आए. उन सब की जॉब की चिंता यहाँ हो रही है. उन सब के खाने को किसी को कोई प्रॉब्लम नहीं होने दी गई है. जो लोग बाहर जाना चाहते हैं उनका भी अरेंजमेंट किया गया हुआ है. तो जो लड़ाई है, जो संघर्ष है, वो एक तरफा नहीं रहा है. और इसके अंदर जो आंकड़े हैं वो 3% से कम हमारे यहाँ डेथ रेट रहा है. और हमारे चाहे चीफ मिनिस्टर साहब हो, मुख्यमंत्री हो, चाहे प्रधानमंत्री हो, सभी लोग बहुत सेंसिटिव रहे हैं. आपका बहुत समय हो गया है, बहुत ज्यादा समय मैं नहीं लूंगा, पर मैं आपको ये बताना चाहता हूं कि उत्तर प्रदेश इस देश के अंदर पूरी जिम्मेदारी के साथ हमारे चीफ मिनिस्टर के नेतृत्व में अपना फर्ज पूरा कर रहा है. आपने हम सबको इनवाइट किया. बहुत बहुत धन्यवाद. बहुत बहुत धन्यवाद.
Thank you very much for a very brief, but your presence is important. I mean, that makes the things more healthy, and I think we have 4 people to speak, 3 minutes each, so that we can wind up. So Dr. Girish Tyagi, who is the president-elect of Delhi Medical Association, is the past secretary of Delhi Medical Council, is a very important person for Delhi. Please give highlight in 3-4 minutes regarding how you feel about Delhi facing the crisis and what DMA is planning to do.
Thank you, Dr. Vivek, because it was earlier it was. Thank you, Dr. Vivek, for giving me a chance to speak on this important platform in which the very high dignitaries are also there. As far as the role of DMA is concerned, DMA means the Delhi Medical Association, which is of course the medical professionals association in Delhi. We have around 15,000 members who are actively participated in and actively supporting the government in the this pandemic. All whether it's the government sector or private sector, we are all doing our little bit in that facing the COVID pandemic. As far as the Delhi Medical Association is concerned, primarily the role of medical professionals is more and more important in this atmosphere, because in the times to come, there will be shortage of manpower, including the doctors, nurses, and the medical other supporting staff. And we have seen that around 3 doctors of Delhi have sacrificed their life in treating the COVID patients, and many of them are recovering at the various hospitals. And in the times to come, as far as the Dr. Mahesh Sharma committee is there, hello, yeah. As far as that Dr. Mahesh Sharma committee, which is considered by the Delhi government regarding that requirement of the medical professionals in the future, it told that by the end of June, 1 lakh positive cases will be there, and by the end of July, 5 to 5.5 lakh will be there. So there will be a huge number of patients in the coming June and July. Of course, we are seeing the last in the month of June that around 2,000 to 3,000 actual COVID positive cases are coming up, and the same is going to be trend in the mid of the July. So the DMA has collaborated with the Delhi government, and we are supporting Delhi government, and because in the times to come when they to increase the bed, government has planning to have beds in that these banquet halls, community centers, stadiums, etc., where the preliminary treatment will be given. Of course, that will most of the time monitoring will be done by that supporting staff and under the care of the doctors. So DMA is training the staff to have, so that the monitoring is better. Monitoring means SQ2 measurement of the blood pressure, measurement of thermal temperature, and the volunteer. When they call doctor or for that particular patient, and we seek the support of that community in the sense that they should not stigmatize that doctor, because now many times it is seen that the landlords where the doctors are being staying at the rent, they are hello, kindly, the other voice is there. So, and we have seen,
I think, let me just see. Yeah, okay.
I think that there is a problem with the.
Now it's okay.
Yeah, now it is okay. So, and we have seen that in Delhi, the hospitals under that North Delhi Municipal Corporation, there are various dispensaries in which the doctors and nurses and paramedical staff is not being paid for the last 3 months or so, and Delhi Medical Association has taken this cause, and now the salary has been released. But we seek the government intervention to see to it that a permanent solution is being taken care of this case, even when the medical professionals are risking their life in treating the COVID patient, they are not being paid salary. That is a pity on the part of the government, and we seek that central as well as state government to see to it that this permanent solution is being taken care of.
Thank you very much, Dr. Girish, for giving the insights overall and giving us hopes that things will be okay. So now we move on to the last three speakers. Dr. Subhash Gupta, he's from Agra. He's a physician and cardiologist. Are you ready, Dr. Subhash? He will speak how he is able to treat his patients. He's a very busy practitioner. He's running Ram Babu Heart Center. He's one of the first to start thrombolytic therapy in Agra. A very senior MD, MBBS, MRCP. And he was working in England. He came back to India from England to serve the country. So Dr. Subhash, please go ahead. What do you want to speak about Agra?
Thank you, Dr. Vivek. In Agra, I'm running a very small center, and very often I come across the patients complaining of symptoms like COVID. But investigations are not available in private sector. It is not allowed by DM. And besides this, we have to decide then and there whether this patient can be of COVID-19 or not. So what I think, I discussed it with my son, Sumit, who is a chest specialist and emergency medicine, critical care. He said that go for CBC, lymphocytopenia, LDH, C-reactive protein, calcium level, and ferritin chest X-ray, then and there. And it gives you the precision of 99%. If it is they are positive, it means patient is COVID-19. Not, then it is he is not suffering with COVID-19. So what I do, I go for CBC, lymphocytopenia. I go for C-reactive protein, and
I think something is wrong in the audio, video. So, Dr. Subhash, yeah, okay, now please go ahead.
And the patient is fear of getting this test done, COVID-19, because he's in fear of quarantine, isolation. In government hospital, the situation is very pitiable. They think I might not die of COVID-19, but certainly I'm going to die of being admitted in government hospital. So I follow this. Now I wanted to know from Dr. Vivek that what to do with the cardiac patients. Suppose you get the myocarditis, raised cardiac enzymes and with the echo findings. What do you do? Should we give the steroids or not? Do you give antiarrhythmic drugs, prophylaxis? If any acute MI happens, then what do you do?
Dr. Yashpaul will answer this question. He will also have the privilege of speaking, and also he's a head of department of cardiology. Please unmute yourself.
Okay, thank you.
Dr. Yashpaul, please answer his question. Yes.
Yeah, Dr. Vivek, in fact, as you know, from the very first webinar and PGI alumni CSI ICC meeting, we were advocating that thrombolytic followed by 2B, 3A along with myocardial protection. The myocardial protection for cardiac patients and those who are at risk, the therapy, myocardial therapy. So that's very important. Definitely, these patients who are having MI should be given low-dose beta blocker and trimerazidine, carnitine, nicorandil. In fact, our experience of COVID-1 and this one was so much that autopsy report which came later on, we started seeing from the 2007 onwards, this is the pathology in the sepsis and viral infections and comorbid diseases. So basically that's helped us to immediately advocate this whole world. I'm really happy that Professor John, he's now this one medical fraternity is agreeing. And unfortunately, we lost 5 lakh patients. But I assure you, with this therapy now onwards, the millions of deaths will be saved in the next 1 to 2 years, because this is a specific therapy for specific patients. The thing is, the patient is sometimes 1,000 miles, and when the doctor doesn't know, on the name of primary angioplasty, he shifts that patient, and in the ambulance, the patient dies. 50% of the patients, they do not reach the hospital. So appropriate therapy, appropriate judicial use, this one will save so many patients in the globe that it will be because you know that we could decrease the mortality by myocardial preservation, by this one thrombolysis, by cardiogenic shock, even the late presenter. We published in Indian Journal also. So basically this is a very important, and I just suggest that 1, 2, that we should that this is the critical time and we should not have the Spanish second flu in which so many mortality occurred. So we have to be very careful that 5 days a week, very intelligent, smartly working, very smartly diagnosing, safe doctor, safe patient, safe hospital, safe industrialist, safe all professions, courts, judiciary, shops. So that it should not be that whole day we should work. We should work 2-3 hours in the morning, 2-3 hours in the evening, good sleep, good immunity, good diet, good iron. In fact, it's very important. Albumin is so important. We sent it to New England Journal. It was not published from there. Then we sent it to the BMJ. It was published there. Albumin is an antiviral that acts so much for this virus as well as for the antibodies. It is antibacterial. It helps in increasing the effect of antibiotics. So the thing is aggressive treatment of antibiotics, iron, myocardial preservation, thrombolytic, followed by 2B3A. I just want to highlight the tirofiban is such a drug. Mayo people, this faculty came to PGI and we were using that. They saw. And in US, without any trial, just on the data, this is the first drug which has been approved by the US FDA. So there was a big news all over the paper that tirofiban is a low-cost drug. If 4 to 8 hours after this, it is used in non-STEMI MI also. We have registered this trial. We have also written to BMJ and giving it to the various organizations, teleconferencing, telemedicine, and teleglobal also. To all states, Ahmedabad, Delhi, as you know, I discussed with many times, Bombay, this all over Kerala, Karnataka. So our aim is that this therapy should go very fast.
Let us have views of Dr. Jack Lewin also on this question of Dr. Subhash Gupta from Agra. Dr. Jack Lewin, please.
Well, I think that he's speaking smartly. You know, I think that we basically have to, in the era of COVID, we continue to have to treat cardiovascular conditions in a traditional fashion. We're treating cardiogenic shock as we typically do. We're treating, but when it comes to a STEMI, instead of PCI, we're going to thrombolytics, and that's because it's safer and it's working for people. I think that in terms of anti-inflammatory therapy and so forth, and antiplatelet drugs, we have to tailor those for individual patients based on their particular risk of thromboembolic disease.
Okay, so that's a good comments and good suggestions from Yashpaul. Asokan, would you please just give few comments, and then we'll have a social message from Charvi, Jain, and Dr. Chinmay Gupta. Madhvi Agarwal had to leave for his TV show. So Jack, please, with just another 10 minutes, you stay back. You are a moral support also.
Thank you.
Asokan.
Yeah, I think first cases reported from Kerala in the month of January, and afterwards we are tackling this disease somehow very well, and we had only few cases. But moment we started the flights from international flights we operated, we had a lot of cases. Now every day we have around 100 patients. Most are asymptomatic, and as you have seen other places, the symptomatic hospitalized group, the mortality is still high. So my question is regarding the experience from Nigeria, where they're not using much of sophisticated methods to treat these patients, because they don't have, they're not much of ventilator, and not using much of digital technologies, and the people also not using mask and other protective devices. I would like to know what's the mortality in Nigeria in this group of patients. One. Second question is to Professor Jack Lewin regarding dexamethasone. What is his experience now? Because the people are using dexamethasone in this situation. I think these are two things. One interesting thing is the experience from Nigeria. I would like to know what is exactly the mortality there when compared with other places.
Dr. Hakim, can you unmute yourself? Yeah, you're okay. we can hear you.
Thank you very much. I want to believe personally that mortality should be much higher than 4% that we record in Nigeria. I did say in my initial presentation that we've had series of mysterious deaths when undertakers have taken in more than what was usual. You were burying 3, now you are burying 15, 20. We don't normally conduct autopsies ordinarily in Nigeria because of so many beliefs. Unfortunately, there was a federal direction and intervention, and autopsies or verbal autopsies were conducted. And it was agreed that some of those mortalities, 60–70% could have occurred from COVID. So unfortunately, because it's been politicized, unfortunately, the administrators came out and denied that the record should be 15–20%. So, but what we, in my view, is that for now, most of our patients are asymptomatic. And I must say, officially is about 4%, with about 500 deaths, with 22,000 patients affected, and many of them discharged. I don't really know. What we do is that common measures that we take, and we isolate those that are really sick. Many other patients are at home asymptomatic. So my sincere response to that is that I think the mortality could probably be higher than what is being reported officially, because we are not catching them, all of them. I think that would be my answer to that.
We're also finding that it's probably wise to treat patients, send people home that aren't acutely ill with, if possible, pulse oximetry, so that people can monitor their, their oxygen levels, and to return only when there is a drop in oxygen. For most patients, this actually works very effectively, and it's a way of saving hospital resources and beds and so forth. So probably ought to be part of the standard approach if we have the pulse oximetry equipment available.
Gupta, not audible. You're not audible. Please unmute.
Okay, Dr. Subhash, that answers your question from Agra?
Yes, thank you very much. Thanks.
Okay, so we go ahead with the last part of the presentation, which will be a small social messages from 2-3 people. So Charvi Jain is the director of Vardhan Plaza, and her father spoke in the last webinar when we were having the business economy. So she would like to give some comments regarding COVID-19 as per her experience. Yeah, okay.
Yeah. Hello, everyone. I'm Charvi Jain. So the COVID-19 pandemic is considered as the most crucial global health calamity of the century and the greatest challenge that the humankind faced since the Second World War. It has rapidly spread around the world, posing enormous health, economic, and social challenges to the entire human population. The coronavirus outbreak has severely disrupted the global economy, and more than 200 countries have been reportedly confirmed COVID-19 cases. So the loss of lives due to any pandemic causes definite irretrievable damage to the society. However, apart from this, COVID-19 has severely demobilized the global economy greatly. Economy of many so-called powerful countries are now facing the threat of high inflation and increasing unemployment as a result of lack of productivity and excessive expenditure for the treatment and rehabilitation of the COVID-19 victims and their families. So in almost all of the COVID-19 stricken countries, entire educational, commercial, sports and spiritual institutions have been closed due to the lockdown that had been imposed. Industries also suffered a lot of loss, as many as those except related to those involved in essential amenities. They were closed for a long time in many countries. So people belonging to the tourism sector and the transportation sector industry also faced many difficulties. So now in terms of healthcare, the society as a whole has become very well aware about the importance of health and hygiene, which wasn't so as much before. So they have been taking appropriate measures like washing hands, wearing masks, maintaining proper social distance, hygienic social habits, and disinfection. So community awareness towards hygiene will have a positive impact in the long term, though in the short term, people are more likely to increase the primary healthcare burden significantly, because many people are more aware of the disease and the symptoms. So even with small symptoms, they run fast to the primary healthcare centers, which creates a burden significantly. However, gaps in cares of patients of other ailments, especially chronic diseases, in the short term can lead to long-term burden on healthcare burden significantly. As urgency takes precedence over important diseases, the entire system focused on prevention, diagnosis, treatment, and containment of COVID-19 infection is likely to miss opportunities for timely diagnosis and treatment of other diseases. So this sector needs to be taken importance that other ailments which are more chronic are not ignored. So patients of chronic diseases have become wary of going out or facing difficulties in movement due to the lockdown restriction. They might miss on treatment, ending up with long-term suffering. These can eventually increase the possibility of complications and worsening of such diseases, raising the overall burden of diseases of the country to a certain extent. So this might be a possibility. So this pandemic has also forced the government to invest in strengthening of healthcare infrastructure in both urban and rural areas. So this wasn't the case before. So this has caused realignment of budgetary allocations on current plan and development work. So the entire priority of the nation has become healthcare. So earlier, not as much as investment was made in the healthcare sector, but this pandemic has forced the local government with focused attention on attaining the healthcare standards in all areas of the country, be it rural or urban. So the importance of this pandemic has resulted in increased use of technology, telemedicine, and training of healthcare workers and mobile hospitals. So the Niti Aayog recently released telemedicine practice guidelines to enable healthcare access and affordability through faster access to appropriate interventions and access to services that not be otherwise available. So there have also been frequent online training sessions for the nurses, paramedic staff, and primary healthcare workers for protocol to be followed for detection, isolation, communication regarding suspected infections. So increased use of technology and opening up of telemedicine through transparent guidelines will further improve access to healthcare even in remote locations in geographically diverse country like India. So with the advent of such disease, importance of technology has been realized by major sectors, which has reduced the need for unnecessary travel, thus reducing carbon emissions as well. So work from home has become quite common and more acceptable by large and small business alike. This has caused a change in the structure of schooling and learning as well, with online classes and online assessment methodologies. However, only a handful of private schools could adopt such online teaching measures, since these facilities are not equally available by government and other private schools. So there has been seen a digital divide, and people who have more access to such technologies are able to avail the maximum during such pandemic. So
thank you. You are speaking very well, but we are short of time, so we have 2 more messages, and I'll get you back again in the next webinar. You spoke a lot about the technologies required and which are in the pipeline. Jack is listening there. So we have one friend from Pakistan who is waiting, and then friend from Paris. They will just a small message. So Uttam, would you like to say something from Paris?
हाँ, डॉक्टर साहब नमस्कार. हाँ, यहाँ फ्रांस में सर सब कुछ ओपन हो चुका है. यहाँ पे कोई प्रॉब्लम नहीं है. अब यहाँ पे जो है अभी जो वंदे भारत मिशन से जो भारत जा रहे हैं, मुझे लग रहा है अनावश्यक को बुला रहे हैं वहाँ पे. उनको बोलिए कि अब यहाँ पे फ्रांस में रुकने का समय यहाँ पे अब नहीं है. यहाँ पे कोरोना वायरस, सभी स्कूल खुल चुके हैं, सिनेमा थिएटर खुल चुके हैं, लूवर म्यूजियम खुल चुका है, एफिल टावर खुल चुका है. टेम्परेचर 35 है आज पेरिस का. अभी 35 बाहर टेम्परेचर है.
Are the new cases not coming at all? Is it New Zealand now?
New cases sir कुछ एरिया में आ रहे हैं. Some areas, especially for the hostels, some foreign people hostels like African people and Romanian people staying in some sites. This side is some cases coming, but French, not French or Indian, not good colonies like that, like Delhi, Saket and something. Good colonies not coming to case. So carefully the people.
We can plan a vacation before everything is totally on lockdown here.
Yes,
we can plan a vacation there. Anshu, will you
तो आइए आपका स्वागत है. आइए आपका स्वागत है.
आएंगे बिल्कुल. I think we have Dr. Abdul Rasheed Khan. Is he ready? Because he wanted to speak something from Pakistan, but I think his video is not on. So may I request Chinmay Gupta to say some words about unlockdown status quickly. Abdul Rasheed Khan is here. So why are you so covered? Abdul, what is happening there in Karachi? I cannot hear you. The mask is avoiding your voice. No, you're not audible. You are unmuted. Something is wrong at your end. We are not able to hear you. Please, I think you should restart your Zoom and reconnect because you're not audible. So, Chinmay Gupta, would you please come back to discuss about the lockdown quickly?
Okay. I am Dr. Chinmay Gupta. The lockdown was never going to kill COVID-19. It was worthwhile remembering, no matter what the WhatsApp forwards about sunlight and clanking pots and pans may have said, and despite outrageous graphs put out by Indian authorities, the lockdown was never going to be a way for India to bring its infected count down to zero. That simply isn't how highly infectious disease works. Indian immunity, then heat and Arogya Setu did not bring any magic solutions. The conclusion suggests that we have to be prepared to live with COVID-19 and with all the safety measures it necessitates. Whichever scenario the pandemic follows, assuming at least some level of ongoing mitigation measures, we must be prepared for at least another 18 to 24 months of significant COVID-19 activity, with hotspots popping up periodically in diverse geographic areas. As the pandemic wanes, it is likely that SARS-CoV-2 will continue to circulate in the human population and will synchronize to a seasonal pattern with diminished severity over time.
Okay, so I think, Jack, I just want to take a last comment about the unlockdown process because personally I feel, although our Mr. BL Santhosh was very happy, the things are very positive going on. And you have, in fact, Mr. Donald Trump himself was very, very quick in starting the lockdown process. I personally feel that there should be some lockdown continuing for a little longer time because even the mortality 5% or 3%, it is when the one patient lost is a loss to the big family. And we can't do anything. I have lost many patients in Apollo itself. Despite best of the treatment, patient who was a husband of a very important police commissioner, he died despite everything, remdesivir, inhalation of nitric oxide. At that time, Vivirapir was not available. They imported everything. They gave plasma therapy thrice, proning the patient lying on the other side, just for 55. So what do you think? The lockdown should continue or should not continue at all? Or should we think of herd immunity? What is your thought?
I think first of all, people who have risk factors, elderly people, people with diabetes and cardiovascular disease and so forth, those people should be protected and carefully protected. In terms of just the great political pressure that's growing around the world to get the economies going again, which have other causes of morbidity and mortality associated with economic collapse, we need to get people back to work safely. So more testing, more careful monitoring of symptoms and temperature, and the typical public health controls in terms of masks and social distancing has got to be done. For those who have antibodies, since we don't know how long the immunity is conferred, and we won't know that for at least a year, we have to be sort of cautious there. But people who have IgG antibodies and have presumably have immunity probably can resume frontline work in high-risk areas safely. For others, we need to do the precautions. The lockdown, I think, is most important for people with vulnerabilities, protecting them from infection. But then if their family is going out to work and comes back home, That's not safe either. So there has to be some concern about really isolating people with high risk from the disease until the virus levels drop. But for the rest of the world, I mean, in New York, we're now down to a very safe level, but we still haven't really opened up bars and restaurants because we're worried about a resurgence of virus again in the population which still has not been exposed. In the rest of the US, they're doing kind of crazy things in other states, and they're seeing a huge surge of new cases. So I think the lockdown's important, but at some point or other, we're going to have to start doing testing and some other safe approach to getting people back to work safely.
I think I want to know again from you, we have 3 types of tests available, in fact 2 more. One is a rapid antigen test body, which takes about 30 minutes, and the government is doing that testing, and this is a it's not a good, it's a highly specific but low sensitive. That means if you are negative, then they will say that please go ahead with the PCR test also. Right. There is of course PCR test, RT-PCR, which we are doing regularly, but that takes minimum of 14 hours or earliest 8 hours if you do a rapid sort of a thing. In that case, what kind of testing are you doing there? This is South Korean kit which we're doing, the government is doing in India, which is rapid testing within half an hour, nasal secretion, and half an hour the test is available. What kind of testing are you doing in US?
Well, we're doing a variety of things, but for the most part, what's most effective, I think, we've looked at the serology or antibody tests, and some of them are very poor in terms of their specificity and sensitivity. So if you choose the right test that has maybe a 95% level of sensitivity and specificity, then an antibody test is a good screening test to see who's been exposed and who's not to diagnose. You need to do PCR at this point.
That's a blood test. That's a blood test. That's a good test. But
it can be done with a finger, with just a finger stick. Although the amount of reagent and the amount of blood is very, very important, or the test can be misinterpreted. So you actually need a new kind of pipette that collects the precise amount of blood and then injects the precise amount of reagent so that the test is more accurate. But what I think is going to come in the near future is a CRISPR technology that will create both an antigen and an antibody test that can be done in 5 minutes, can be done at point of care at home even. And the FDA just this week gave Quest Diagnostics, the biggest lab in the country, permission to begin a point of care home test. And this is going to be an antibody test. But we need a better serology test. I think the CRISPR test to test the antigen with just a very, very easy little swab and a 5-minute result is what we need. So we don't really have the ideal tests yet. We don't.
When is this likely to come, this CRISPR test?
We think this will happen sometime by the early fall of this year. So maybe 3 months or 4 months from now.
Oh, that will be a great thing, because 5 minutes nasal secretion and you get the antigen.
Yeah.
And secondly, which I was thinking of my question, and to all the panelists here, I mean, that if you do the antibody testing, and if you are having enough antibody, whatever way, maybe asymptomatic you are, then you can move and freely around. But how long this antibody would last, that is a question, because we don't know. We have seen from China, there were reports that 4 months down the line, the antibodies are finished. So it's a very strange situation.
Well, however, it may very well be that even in the asymptomatic patient, the antibody levels can be low. Maybe, however, the T cells and the beta cells are able to produce antibody again. So it may very well be, we don't know yet, but people with low antibody levels may have the ability, their immune system may have the ability to manufacture antibody if they're challenged again. We don't know yet. Just a lot we don't know.
Let me tell you my fact of history. I'm coming to Apollo Hospital every day. Not even a single day missed during the last 20 years if I'm in Delhi. So, I mean, this is a record. And I popped this, I take the hydroxychloroquine. Asokan, please listen. Although it's not mandated, I take it to an alternate day. According to Indian Council of Medical Research, you take it once a week. So what I do, since I'm getting there, I'm seeing the patients, I'm seeing the family of the COVID-19, although from a distance, you can see this is my room. If I turn around, this is the gate. So I let them stay at the door, and then they don't come in. But my children are the family is not happy, and they always scold me when I go back home at 11 p.m. that please tomorrow this is the last day you're going to Apollo. So this is happening every day. So, but unfortunately, we have to be very careful. There's no doubt in that. We have to be careful. And so I just wanted to finish this webinar. I think everybody's spoken. Anybody left out? And if do you mind, because there are a lot of people seeing. Can you show me New York again? I love it. You have to go out for a while. Is it possible? Jack?
What? I'm sorry, I didn't hear the question. Say it again.
Not a question, it's a request. Show the New York again.
Oh, of course, of course, of course. Here we go, see it.
Dr. Das, he's on 40.
Here we are. We're looking south now. There's the Freedom Tower, and that's the south part of New York. Here is a new 110-story building. Here is the Hudson River, and there's New Jersey over there.
It's looking beautiful, eh? Yeah, one more time. Hudson River. Yes, yes, yes. Okay.
Never know you would never know that COVID is lurking, would you? It looks beautiful.
That's true. That's true. Any last comment from Dr. Das? We have to finish this webinar now. It's already long. Yes, Mr. SC Gupta is also there. He's from Lucknow, our family friend. Abdul Rasheed Khan is not able to join back. Any last comment from anybody? Charvi will be taking Charvi Jain again in the next webinar to complete her. Oh, Abdul Rasheed Khan has come back. He wanted to say from Karachi. So let us have a last comment from Abdul and then PK Das, and then we'll finish off this webinar. Abdul Rasheed Khan, why are you covering your face? Sorry, he's muted. Please unmute yourself. Yes, okay. Please speak. No, the voice still not coming. Are you planning to go to space? You're not audible. You're not audible. I will take you like this in the next webinar. I'm sorry, yeah. Jack, Karachi is protected. They're protecting from covering. They're doing like this at the home. How do you sleep like this? So, unfortunately, you're not audible. So I think something is wrong at your end. Dr. MK Das, to final words, and then we finish off this webinar. Okay.
Okay. Thank you, Dr. Vivek Gupta, for actually presenting this series of COVID information to all the public and doctors who are really being benefited, especially by bringing experts from all across the world. Actually, you are doing a sort of great job. I am really thankful to you, and congratulations to you. Thank you very much.
I think this is the time, Jack, to finish off the webinar. It's already 2 hours, and I'm happy to know that Paris is open. So if Paris is open, the New York is open. So I don't know whether we're going to have the ACC. I think will happen. I'm sure ACC will happen in March.
It will. It will happen. Yes. We'll be by that time when things will be okay.
Because TCT is already, I think, virtual. I think they've announced, or Greg Stone.
Yeah, I think so. I think the TCT is going to be virtual this year, unless something changes very soon.
Okay, so I thank everybody, all panelists. In fact, Mr. BL Santhosh ji spoke a little very positive approach of India. Jack, were you listening to him that what Indian Prime Minister, Indian leadership has done? He spoke very well. He said, except for three big cities which are suffering, the rest, despite unlockdown, the other cities are doing well. Uttar Pradesh Health Minister was there. Asokan is always there as a friend. Charvi then spoke a lot about the whole world Indian scenario in different ways. Chinmay spoke about the things, what about, and Yashpaul Sharma is always proactive for Tarifaban, and he says don't do angioplasty at all. I think once the cath lab is open, he will still continue to say don't do primary PCI, continue with Tarifaban and thrombolysis. He's wanting to say something. Okay, he wants to say something. I mean, it's too late, eh? And I thank everybody to say goodbye.
Thank you, Vivek.
No, just, he wants to say 30 seconds, not more than 30 seconds.
10 seconds.
Okay.
Judicious use of primary angioplasty and in infected cases, thrombolytic. The thing is not primary, because primary is not in that way. You do not do the test in primary angioplasty, the case excluded. If you see the list of primary angioplasty, the cases which infected cases, renal failure, comorbid, all were excluded. If you can exclude those cases, it's fine. Otherwise, on the name of primary angioplasty in the infected cases, otherwise there is a futile diagnosis. Futile, this one, which new guideline has come.
Okay, agreed. Jack agreed? Okay, the only thing which I missed today was a song. So we did not involve a song because it would, if anybody can sing a song after the people who are suffering, I'm ready. Otherwise, we finish this meeting now. Jack, would you like to say something, some American song?
I don't want to. I think I might cause everybody to leave very early, very quick.
Okay, thank you, Asokan. Thank you, everybody, and Uttam Rawat from Paris. And we end this meeting now. We hope to meet the next week again. And we would like to have a request. I'm personally thankful to Jack to take my case changes very quickly and be able to do the webinars on short notice. Thank you very much. All of you, Dr. Das, Asokan, Yashpaul, everybody. Thank you very much. We're ending the meeting. Thank you.
Bye-bye. Bye-bye, Dr. Dev.
Bye-bye. Bye-bye. Bye-bye.